Hello, everyone. I'm Dr. Jennifer V. Brown, your stroke specialist, and today we're going to talk about rehabilitation versus habilitation. So let's look at the difference between rehabilitation and habilitation. Rehabilitation is relearning or restoring a skill or an activity after an injury. For an example, you have an adult with cerebral palsy, independently functioning, working, and then has a stroke. There's damage to the anterior and lateral cortical spinal tract. So they may have weakness in their proximal trunk and weakness in the arm and the leg. Their goal is to learn how to sit again without having to use their arms to stabilize the trunk. The insurance modifier for this is 97. Now, habilitation is learning or teaching a new skill for the first time. An example would be a baby with cerebral palsy learning to sit for the first time. And maybe their sitting is delayed and they're learning how to sit at the 6th or 7th month when you usually proper ring sit with your arms for support at 5 months. This baby has no previous recollection or experiencing of sitting. So again, in habilitation, you're learning the skill for the first time. Its modifier is 96. Now, habilitation and rehabilitation have some things in common. Maintenance is a key component for both after you have either relearned the skill or learning it for the first time. And for order for them to maintain that skill or activity, we have to make sure that we apply compliance versus adherence correctly. Compliance is to do the skill or the activity exactly as it was taught and learned. However, sometimes we're learning things in a clinical setting, outside of the home, in a sterile environment. And therefore, they may not be able to do it exactly the same in the home. So, therefore, adherence is what you really strive for. You want the person, and with the help of the caregiver, if need be, to take what was taught and make sure it can be done adaptive for the environment that you are in. You want them to do it, but modify it as needed so that the task or the activity can be accomplished. So when you look at that, the difference between habilitation and rehabilitation, you can look at the population served and say, well, how are we going to make adherence work? So with these conditions for habilitation, you have developmental delays, and so things have to repeat it consistently, and you may see that there's a plateau in activity. You have congenital conditions where people may get progressively sicker if they don't get better. And so again, you may have to modify things over time that they have been taught. And then in this population, they have early onset disabilities. So things may have to be repetitive for a reason without not any necessarily gain in function. So we really have to look, how do we manage that over the long term? And let's look at rehabilitation. Remember, it's a loss of a learned function, or you cannot do something due to a medical condition. Now, that doesn't mean you can't do it afterwards. You may have to compensate because you can't do it the way you normally did prior to the injury because of a loss of motor and sensory neurons. You know what you have to do, but maybe you can't do it because of quite a few reasons: cognition, loss of range of motion, a loss of strength, sensory loss. Okay. But does that mean that for the lifetime of the person, they always have to get something in terms of therapy to maintain and adhere to their program. I'm of the school of thought that people need a tune up, but we have to engage in some type of exercise or physical activity, whether you are in therapy or not, for habilitation or rehabilitation. And we have to make it person centered. So, what is it that we have to do as clinicians to assure that there's an outcome for function, whether you're a pediatric with a onset of early onset of a disability, or you're a pediatric who had a stroke in utero versus an adult who's already learned some type of task and has had a injury or some type of medical condition for them to learn to lose that learned skill. So we have to treat as if we want neuroplasticity to happen. In younger brains, it's easier. But are you still doing something that will entice the patient to do repetition, high intensity, things that are salient, that matters? All right. And what is it that you're going to do different in physical activity versus exercise? Because exercise is a planned routine with a set number of repetitions and it's done repetitively, versus physical activity can be done different ways, like rolling. All right. And so, how you do rolling, is it going to be segmental, log rolling? Are you going to roll up a hill, down a hill? How are you going to do these things? Okay. So, you have to pick that the person will love, enjoy, will be engaged in that. And then, what's a big determinant of person centered care is the social determinants of health. Um, are their finances appropriate for them to engage in a therapeutic session, be it habilitation or rehabilitation? um, Education access and the quality of that education. So their level of understanding, or the caregiver's level of understanding of what's about to happen is so very important. Are they able to basically read what's on the paper or in the instructions? All right. Can they follow what you did in a video? Okay. And then healthcare access and quality. Are you going to be seeing this person one time a month? Are they in a rural area? Are they even able to get to therapy? Can they even do telemedicine? Rural areas, they may not have access to internet. And then the neighborhood and the built environment. Everybody just can't go to the quote unquote mall and walk for exercises. And if you're in a rural area, you have to think of uneven terrain in which they walk because they're not sidewalks. Okay. And then social community and context. Who cares for them? Who are their group people that they're with? Are they in a home for kids with disability where there's one caretaker for every five people? And how do you engage in a daily program that's needed for habilitation versus rehabilitation? All right. And that's along the age spectrum because you have children in group homes and you have adults in group homes. So all of those things matter. Think about these things as you do your programs for your clients, paying particular attention to their diagnoses and their age span and what's appropriate, because you just can't keep having therapy forever. We have to encourage the client or the caregiver of the client to be involved in the art of practice, which is physical activity or exercise as they see it. And we are coaching them to get to that point. I'm your trusted source for all things ankle foot orthoses and neurorehabilitation. Don't forget, like and subscribe, leave a comment, and don't forget the references. Evidence-based practice for the best clinical practice. Like, subscribe, and I hope you enjoyed the video. Please share it. Thanks. Bye.